Good morning, everyone, and welcome to the 18th Annual Homeless Summit. I'm Wayne Niederhauser, the State Homelessness Coordinator, and we welcome you all to our annual summit. This is my first summit. I've been in this position now for a little over 6 months, almost 7 months now, and it's been a pleasure for me to tour the state and visit with many of you and to learn statewide what is going on with homeless services. It's been an eye-opener for me to see how much good is being done across the state and recognize that homelessness is a statewide issue. And so I look forward to working with you in time to come, many of you, and look forward to visiting also a couple of the local coordinating councils that I've not visited yet in Moab, Vernal, and in Blanding. So anyway, we welcome you to the summit this morning. Stephanie, I think next slide. So my position was created, as well as the Office of Homeless Services, was created by House Bill 347 in the last general session of the legislature, which is January through March. The bill created this position in the office under Workforce Services. The bill modifies provisions related to individuals experiencing homelessness. It created our positions and the Utah Homeless Council, and lays out the details of the role of the coordinator. Next slide. The Office of Homeless Services now is organized in as shown here on this slide. And it's kind of a unique position, my position, because I actually serve under the Governor's Office of Planning and Budget. And then the Office of Homeless Services is now a sub department of Workforce Services, as you can see on this chart. That's a little bit new, a new concept. But those who drafted this legislation, those who got behind the legislation, wanted the coordinator to be in direct line with the governor's office, so there'd be some clear communication lines right to the governor, showing the importance of homeless services, of homeless issues in the state, making sure that we had those direct lines. The statute also requires the coordinator, myself, to report to the President of the Senate and to the Speaker of the House on a semi-annual basis. And with my background, many of you may know that I served in the legislature for 12 and a half years between 2006 and 2018. I was a Senate president for 6 of those years. And I know the Speaker and the President very well, and also worked very closely with the governor, who was the lieutenant governor at the time I served as Senate president. But as you can see there, then we have Tricia Davis. I know all of you know Tricia. She's been around homeless services for several years and has played a big role, and appreciate her knowledge, her understanding of the system, and also her acquaintance with all of you. And then Stephanie Leeds is our administrative assistant. Russell Goodman, our program manager, data manager, Joseph Jensen. Under the program, we have Lainey Myers, Mary DeMasters, Carol Nilsson, Kelly Koster, We also have our data manager, Joseph Jensen, and under him is Haley Hinckley, Michelle Walton, Lynn Sharp, and Zach Guthrie. And many of you already know many of these individuals. We appreciate their service. We appreciate you coordinating with them. Next slide. We've also, with House Bill 347, we also created the Utah Homelessness Council. So the council and the coordinator have some responsibilities laid out in statute. And one of those is to maintain the homeless services budget, maintaining the strategic plan. We already have a strategic plan in place, but we're going into a process now to revise that strategic plan. We'll be reaching out to many of you over the next months to start to develop that plan. We review applications for funding, approve that funding for provisions of homeless services. The council also ensures that services provided to individuals experiencing homelessness are to be used in a cost-effective manner, and that the whole system works to facilitate a better understanding of homelessness. It also is important that we point out that one of the big reasons for the creation of this office, my position, and the new council is to coordinate these efforts on a statewide basis. This is coordinating with Health and Human Services, with law enforcement, transportation, because homeless services, homeless issues crosses many of these lines and departments, and having a more coordinated effort was the purpose of House Bill 347. Let's go to the next slide. Many of you will recognize this chart. This is how homeless services is coordinated across the state. One of the first things that was a challenge for me was to understand the structure and all the acronyms that come with homeless services, and it's been an education for me to understand how this organization works, and we've proven, and I think that it's a proven best practice that coordination on the local level is critical. So we have our coordinating councils across the state. The balance of state, which is 25 counties, and most of the coordinating councils is under the state of Utah. Plus there's the COC that's in Salt Lake, which is the Salt Lake Council to End Homelessness. Didn't get that quite right. There's too many letters in that. And then we also have Mountain Land, which covers 3 counties. These are critical, and we appreciate being able to work with those councils and coordinate on a state level. And this whole structure is going to be critical as we coordinate on a state level in the future. Let's go to the next slide. So we look forward also, I look forward particularly to reaching out on the vision for our homeless services to make homelessness rare, and address the issues with homelessness, increasing outreach, improving customer experience with providers, and ensuring mental and behavioral health needs are genuinely met. This is one of the things that I really didn't have an understanding. When we're dealing with chronic homelessness, it's not as much about housing, although a person needs a stable housing situation to heal from the trauma that they've experienced in life, whether that comes from reentry, whether that comes from domestic violence, whether that comes from aging out of foster care, intergenerational poverty. We all know the places where people come from and get into homelessness. It's domestic violence. And so it became apparent to me early on that, yes, housing is necessary and we need to get people into housing first, but that there are a lot of behavioral and mental health issues that need to be addressed, and that we also need to be focusing on that once people get into housing. And this is what we'll be focusing on as a council, as an office, what I'll be focusing on as a coordinator in the future. And as we begin to develop our strategic plan, is how we can now, once people get housed, how we can get them to a better situation in life, functioning in a better way in society and living a more healthy life. Let's go to the next slide. I want to make sure that we thank those who have been on the planning committee. As you can see, the Office of Homeless Services are participants there. Next slide. And also our Utah Homeless Network and that planning committee. We appreciate everyone that has been serving as we planned this conference. And now we look forward to a great conference. There are many breakout meetings that you can go to. We've got some great presenters, and we look forward to the next couple of days to spend some time together, asking questions, receiving information. And so we'll move forward from here. I think now it's 8:58 now, and we've got Dr. Sam Semberis with us now, and we appreciate him joining us. He will be our keynote speaker this morning. I want to read a little bit about him, his bio, and we welcome you, Dr. Semberis. Dr. Semberis is a clinical community psychologist who originated the Housing First model, based on the belief that housing is a basic human right. Since opening the original program in New York City in 1992, Dr. Semberis subsequently opened programs in Washington, D.C., Philadelphia, Burlington, Vermont, and Atlanta. Evidence from randomized control trials report housing stability rates ranging from 80% to 90% for individuals who are literally homeless and diagnosed with severe mental illness. The Housing First program has been adapted to serve populations exiting hospitals, jails, and domestic violence. Today, Pathways Housing First program is implemented across the US, Canada, the EU, Australia, and New Zealand. Recently, the program opened in the South American countries. Currently, Dr. Semberis serves as the CEO of Pathways Housing First Institute and clinical associate professor, UCLA Department of Psychiatry and Biobehavioral Sciences. He provides training and consultation to communities on Housing First. He's published widely on these topics, including 2 books, and his work has been recognized by the American Psychological Association and the Meritorious Service Cross from the Lieutenant Governor of Canada. He has worked with the people of Utah to introduce Housing First to the state and is pleased to return and participate in the summit. Doctor, thanks for being here. We'll turn the time over to you and look forward to your presentation.
Thank you very much, Mr. Niederhauser. I appreciate the introduction. It's great to be with you. And it is actually heartening to see that someone of your stature, knowledge, and experience has been appointed to this state homelessness coordinator position, signaling to all of us the importance of this issue for the governor and the legislature. I think that's a great start on an initiative, and it needs that kind of support to move forward. So it's a pleasure to meet you, and I look forward to working with you and being of any assistance to the state that I can be.
Thank you very much.
Good morning, everyone, and it's wonderful to be invited back. I'm honored to be back. I've been to Utah several times. Initially, around 2005, when at the invitation of the late and great Lloyd Pendleton, at that initiative launching Housing First in Salt Lake City, and then returned several times to meet with the team at the road home and to work on that implementation. Came back 2012 to this summit, actually, when I was invited by Tamara Kohler. And it was 7 years after that launch where we were actually celebrating at that summit a 90% reduction in chronic homelessness in Salt Lake City, which was really an incredible accomplishment. And it really speaks to the experience of the state through the years of what's happened, addressing homelessness, bringing it down to almost zero. Now we're back to numbers that were there before all of this started. And so my presentation, I'm going to bring up my slides here, is really about post this thing. I think I need to have the share screen function turned over so I can show my slides, if that's possible. It says that the host has disabled participant screen sharing.
Sorry about that, Sam. I'm working on it right now.
Okay, thank you. Well, what you'll see when I have these things up is what I'm hoping to do in the next hour is to really talk about some of the experiences, the lessons learned, and to reflect on. Oh, here we go. Reflect on what's been learned, what the evidence has shown, because there's been a lot of knowledge, in the time that we've been working on this, and also where do we go from here? I believe this may be the one. Okay, let me. Is that slide showing, or is that the right view?
Yes.
Yes. Okay. So you see the slide. Okay. Okay.
Yeah, it's just so you know, it's not on the presenter view.
Okay, so let me see if I can get that fixed. Is that any better?
I I mean, we can definitely see it. It's just, we can also see the notes section.
Okay, let me see if I can, I'm sorry, I don't really know exactly why that. Okay, stop share for a second. Let me go here. Okay, I mean, when I hit the panel to is that better?
You stopped sharing your screen.
Oh, I'm so sorry.
Nope, that's okay. And even if it ends up being in the presenter view, we can still see it. So
Yeah, of course. Okay. Are you seeing it now?
I am not.
Mm-hmm.
Sam, down at the bottom, just click that share screen that you see in the
Yes.
Zoom. And then I think that it was okay the way that you had it, if you can't change it.
Right. But
There we go. Perfect.
oh, okay. Now you're seeing the slides?
Oh, no, now we're seeing your Zoom screen. So just click on your presentation.
Okay.
Yep.
You see it now?
Yep, we see it. And if on your presentation, click the presenter mode, it should be down at the bottom.
Yeah. And
That'll
that's
work.
what this is what comes up. I'm sorry.
That's all right. That'll work.
Yeah. All right. So that's the outline. And I want to talk about just many things have changed, but some things have remained the same. So three things that have remained the same is that we have not made any progress in changing the public's view of homelessness. Through all these years, the solitary figure that we see on the street is still our image for the public. In the public mind, this represents homelessness 90% of the time. Whereas we know that, in fact, homelessness is much more complicated than that. Families, victims of domestic violence, young people aging out of care, as was mentioned. But we don't see that population as often. And so we continue to have a public perception and then a public policy that is all focused on addressing chronic homelessness. While this is a very important group and probably the most vulnerable group to address, it's important to bear in mind that a comprehensive plan that coordinates all homeless services has got to be greater than just including people who are chronically homeless. The reason people who are chronically homeless come to our attention the most is that they are also the most expensive and the least well served. Most people are going in and out of jail or hospital or inpatient services. And this 15% of the homeless population is accounting for as much as 50% of services for the homeless. The other thing that we do and continue to do in homeless services is that we are still using a methodology which is the point in time count, the one night, usually the third Thursday in January, to count people who are homeless. So it's almost a purposeful undercount, and we know there are many more homeless people than just those that show up on that cold winter night. And we usually measure it from like 10 at night to 7 in the morning. So the problem with that is not only do we not have an accurate number for the people who are homeless, we also are reporting a number that is low, and services and funding allocated to homelessness then is inadequate to resource the actual number of people who are homeless. So we have an issue with the count on many levels in terms of allocating resources. But the count is informative in some ways. I mean, in the last count in 2020, we had some 580,466 people counted. That was the 2020 census. About 70% were individual, 30% were families. Nationally, 40% of those experiencing homelessness were African American, 40%, while African Americans only make up 13% of the population. And one of the more troubling findings is that the average age given for when a person enters a family homeless shelter is infancy, which means that there's far too many children being born in family shelters and begin their first few years of life in that. So we have a problem with the methodology on the resource side, and also on the representation of how we address homelessness in general. We are also inconsistent, and in some ways we're very divided in the approach, in a community's approach to homelessness. It ranges between an enforcement policy to a compassionate social service policy. And you see that on both sides in the community, sometimes appearing simultaneously. You have stepped up enforcement, and people who are homeless are receiving violations or citations for crimes essentially related to homelessness, public intoxication, trespassing, often using public transportation without paying, stealing food, and so on. And then that results in police time, court arrests, and all of that for the person simply to return to homelessness again. Also on the kind of not user-friendly is this urban architecture, hostile urban architecture, which is more and more an effort to keep people out of downtown or other public areas. Like you see these benches that you can't allow the person to lie down, or spikes along a building, or other ways that the architecture has been designed not to make public space comfortable for people. So we have those two divided approaches, and when you have that kind of division, it's hard to make a consensus and move in a particular direction consistently and over a sustained period of time, which is what is needed to address issues like homelessness. I mean, we've learned a lot, even in this pandemic, in that some of the states that are divided about the approach to the CDC mandates on mask wearing. When there's no consensus in a state, like notably Florida and Texas most recently, the ways that a public health issue is being addressed is really having poor results. People are getting sicker and dying in those states more than in states where there's a consistency in approach. And with these large social issues like homelessness, like addressing a public health pandemic, the unification of approach and the consistency of approach is hugely important to achieving positive results. Another persistent problem and division in our field is the treatment first versus housing first approach. That continues in the business. I think that housing first introduced about a decade after treatment first, and they've been operating kind of parallel in most places. And there's still substantial investment in treatment first models, still the predominant approach, I would say. And there's increasing presence of housing first, but not as much as we need and not at the scale that we need it. One of the things I hope to make the case for today is that the lessons that we learned from the last implementation of Housing First statewide in Utah would be useful to inform the current implementation and coordination. And I'll try and outline some of the reasons in which that might be possible. So I think you're all familiar with this approach. It does assume certain things about people who are homeless. It assumes that the homelessness was caused by their own actions or choices, that they're not motivated, and they need structure, rules, and curfews. And housing in this model is offered as an incentive to get sober or to go to treatment, and then you'll get housing, or as a reward for participation in treatment. And so it does require that a person address these very substantial clinical challenges while they're homeless. And we've seen from the research that while that works for some people, it leaves a great number out. And so we developed the Housing First approach to address that group of people that were not able to or willing to try to go up the stairs one more time. Well, here's the thing that's probably, and this debate, by the way, housing first or treatment first, really came to quite a controversial point of contention during the last federal administration, where both HUD and the United States Interagency Council for the Homeless were arguing for a return to the staircase model. Ben Carson and Robert Marbut were talking about housing forth, dealing with the root causes, as if the root causes were mental illness and addiction. But if root causes were mental illness and addiction, just from a very practical perspective, we would have many, many people on the street, because mental illness and addiction is much broader than just for those people who are on the street. In the population, we have many people with mental illness and struggling with addiction, but they have families and resources, they have jobs, they have other supports. So there's no direct correlation between having a mental illness or struggling with addiction and being homeless. Being homeless is about poverty, and often the people who are poor don't have the connection or resources. They have additional challenges, but it's not a root cause of homelessness. Also, homelessness, is only something we've had in America for the last 30 years, since the early 1980s. And mental illness and addiction was here from the beginning of time, really. People started living in groups and documenting it. So it was a shock and a wake-up call to somehow the evidence for one approach doesn't matter. Like it was political will that was driving an ideological perspective rather than based on the science. And I want to review the science so that we're all clear about what really makes sense, and what direction to go. Because if we don't base it on something that's more empirical, then we're going to be debating and not moving forward. My hope is to make a presentation that will bring us to a consensus about this. Okay, the first thing about Housing First is that it's not actually about housing. Okay, Housing First is not actually about housing. It's about how we treat people. It's about, it came out of a psychological approach called psych rehab. And it really changes the dynamic of the social service mindset to the provider being the expert, to the client being the expert of their experience and being completely included in the participation of any plan that is about them. One of the consumer movement mantras was nothing about us without us. If you are a group of case managers or clinicians making a plan about a client, that client should be in the room participating in their plan about their life. So it really was that shift to include people at the table if we're going to make plans for their life. See them, treat them respectfully. We treat them as having opinions about what matters to them most, that they know their own priorities. And our function then is not to prescribe and lead, but to facilitate and support that plan. This way of working is fundamental to building what we all value, self-determination, the mastery and a kind of an independence from needing services indefinitely. The program starts with not with housing, but it starts with asking the person what it is that they want, so that it's their design that is being followed. And underneath that is also the message of you're in charge, you can do this, and we're going to support you. So you're building autonomy and independent thinking and decision-making right from the start. So that's the reason that we're so, the Housing First emphasizes consumer choice and consumer voice so much. The program does not look to fix people. It looks to help people reach their goal, okay? So what happened when we took this psychiatric rehabilitation approach to the streets, it was evident right away that the person wanted a place to live. That's what their priority was, and we figured out ways to make that happen as quickly as possible. A rent subsidy, a Section 8 voucher, or shelter plus care. We have any number of ways of paying people's rents in the community, and then robust support services. Without the services, as Mr. Niederhauser pointed out in his comments, without the services, we will not succeed. People that we're housing have health, mental health, and addiction issues. And if we put them in housing and don't have the robust supports to follow along and help them keep that housing and move on with their lives, we're going to have people going in and falling out very quickly. But we don't require sobriety or treatment participation as a condition of housing. That actually happens after people are housed, and it happens more easily, and people can be engaged more effectively when they are when they're housed and they have a place to live, and security is not an issue for them. So the program is very well documented. There's manuals, there's videos about how it works, and I know there's people on the call maybe have not heard. I'm going to just take a few minutes to describe its actual operation, just so that we're all on the same page. Because one of the things that's happened with Housing First being a kind of a popular phrase and used widely, now even HUD in their applications at the continuum of care requires the applicant to say, will you use Housing First? And if you check the box saying yes, you'll get an extra couple of points on your review score. But that doesn't actually mean that you're doing Housing First, or there's no follow-up to see if it's being done. So lots and lots of programs are saying they're doing Housing First, but it's not clear how many are actually doing the program. So I want to just outline it for you just to make sure we're on the same page about Housing First is about the way you treat people. It's a consumer, person-centered approach to housing and services, A. And that is defined by inviting the person to make choice about their priorities, separating housing from services, matching the needs that they have with providing the services that match those needs, and a recovery focus. I'll just say a couple of things about each of them very quickly. The program does have requirements. It's not like a laissez-faire program where you come into housing and do what you want. You have to meet the terms and conditions of a standard lease like everybody else. Most of the housing that Housing First provides is a scattered site rented from community landlords, but it can also be in a single site building where there are a number of units. I mean, many of the units in that initial Salt Lake City program, the conversion of that Holiday Inn hotel to studios and 1-bedrooms for individuals and families, for examples, a harm reduction approach to permanent supportive housing, is also a viable model for that. It depends on the community's sense of, where you can build housing, where you can locate housing, and the renting among the community in the affordable housing range, which is of course a diminishing number, but large enough to house the small group that's chronically homeless. And most of my comments here are, if we're going to prioritize an approach to ending homelessness, let's start with the chronically homeless and build up from there, because that'll both take care of the people who are most vulnerable, taking up most of the system resources, and also we'll have learned to work together as a team, and we can address the other populations going forward. It has to be a multi-year plan, staged in a way that builds on the lessons learned from housing the previous group. So yes, the terms and conditions of a standard lease and a home visit is mandatory. HUD has got this wrong both times. Once, there's no treatment in Housing First, and you have to have treatment in Housing First. It's neither. The truth is, you don't have to be in treatment to have Housing First, meaning you don't have to see a psychiatrist or participate in a drug rehabilitation program, but you must agree to a home visit. It's not housing only, it's housing first, but not housing only. So the person visits, and the visit is about a well-being, a wellness check, how are they doing, and then engaging in treatment conversation or employment conversation or family unification or participation back in the community, where someone who's been outside, exiled in plain sight in that community is now a member of that same community. All of that takes an artful and persistent and kind approach to re-engage people to move forward in their lives. That's the goal that they have for themselves, and the one that we want to support. The relationship with the person is important. These programs that are designed to go from coordinated entry to outreach to coordinated entry to referral to someone, a housing specialist, and then another case manager. The multiple handoffs, people get lost, and we're not interchangeable, and neither are the people's feelings about how they're being treated. It's best to design programs that have continuity of care from street outreach right into housing and beyond, because the relationship builds on itself. It takes a while to get to know people, and knowing people is the best way to understand what their priorities and problems are, so you can address them. So it matters. The relationship matters. In fact, it's the glue that brings people across these different services. You can't ship people. It's not FedEx. So that's one of the more challenging, these are some of the challenges that Housing First programs, even when they're done well, face. One of the challenges is this idea of you don't have to be in treatment, but you have to have a home visit. And also that it's the person's choice. So you often have situations where the person is housed and like, I'm fine, I don't need anything else, I'm okay, I feel safe. And that they're still struggling, they're still not well. And so the question is, how do you continue to actively engage a person when they feel like they've already reached a place of comfort? And that is a skill set I think that we need to think about and develop in terms of our clinical ability to engage those that don't feel the need, and also to encourage them to think about a life beyond just safety and security. We want to go beyond maintenance. Housing stability is great, but it's not the end of the road. It's the beginning of another journey. And we want to convey that to people. And at times we have to work harder to let them know that there's more in life that's possible than just having this place. And that is the relationship, and that is part of the work of us carrying the hope until they feel it themselves. The other part about this relationship with the client is that the program commits to the client, not the housing unit, right? The housing unit is just one of the services we offer, like transportation, treatment, and benefits, housing. So some people might lose an apartment or might be evicted, but they don't lose the case management support. Those are separate things. You lose the unit, you might get, you have to go to the hospital, you might relapse, you might go to treatment, you might get arrested. There's disruptions in stays, but there's no disruption in the continuity of support. We will follow and visit people in the hospital, in jail, or wherever they are, and get them back into housing. So it allows for that continuity of treatment through disruption. And sometimes, a good number of people, 20%, 30%, may need that second apartment to learn how to manage the visiting with friends and managing really what a good tenancy is about. So it's a harm reduction approach. There's a great learning that happens with loss. There's a lot of shame and difficulty in just accepting that failure and encouraging the person to try again in another place. But having that continuity makes that possible. Another thing that Housing First programs, because they're usually a rent supplement and case management services only, is that we need a different function. Sometimes it's in the form of a fully dedicated staff person. Sometimes it's just like part of the job description, depending on the size of the program. But we need someone that will help the client navigate the real estate market and rent a place. If you don't have a single site building where people are referred to, this is the Housing First program, but you're actually shopping for an apartment. Someone who has been homeless for a while and doesn't look that well is not going to be a prime candidate for landlords to choose. We need to represent our clients to landlords, assure landlords that their rent will be paid because there's a voucher or other rent stipend involved, and that's a huge comfort to landlords. They don't have to worry about where the rent is coming from on the first of the month. And also that we represent to the landlord that we're there to help this person, and if there's any issue with this tenancy, we will be there, respond to the landlord needs. That's part of building a landlord and community network that's going to be viable and have us succeed in expanding that landlord network. We need to be there and provide the kind of support. And I would go further and say that we should think about, in a budgetary perspective, putting money aside for apartment repairs, furnishing the apartments, of course. Putting someone in four walls makes no sense. Furnishing the apartment, relocation costs, and also any other costs that would indemnify the landlord from any damages that are caused by tenants that we have brought in. It's not a lot of money, but it's a very important component of the budget to have this in place, because without community landlords participating, we're not going to be able to build enough, permanent supportive housing anytime quickly to house the group that's chronically homeless. We need the landlord engagement, and we need to pay attention to that function. Matching services to needs is another part of this, which is that we have people who come in with all kinds of issues that they need to address, and sometimes we only have a case manager. And I think it's important to communicate to the person that we may not be able to directly help them with everything they need, but that we will work with other agencies, and this is where you need the collaborative approach of multiple agencies in the community working together in a very flexible way to accommodate and welcome clients that they're not used to working with, so that we can provide and support the client in all of the needs that they want. The other thing about case management is that it's usually focused on treatment and addiction and benefits and the rest of it. Whereas, that's very important, but it's not really a life, And one of the more interesting developments recently in the last few years, there's been a movement to help people who are particularly in the medical field, physicians and nurses, to expand their view of what holistic health is about. And this actually started in England, but it's been brought into Canada, and there's some small experiments here now in the States. And the idea is to encourage the practitioner to have a holistic view. And what they started to encourage is to have the medical personnel write prescriptions to the person for things like arts and cultural activities, green space and gardening, how to get advice about budgeting, physical activity, leisure activity, joining a library, learning or continuing their education, volunteering, making sure their entitlements are in place, reconnecting with family and building new relationships, getting a job, if they have any legal issues to attend. Essentially, all of the kinds of things that make for a meaningful day where the person wakes up and feels like they have something to look forward to and people they want to see. That's what we're talking about. So move it beyond the lens of what is treatment to what is a quality of life, and think about it in those broad terms. It takes training and it takes focus to get there. I think that the core competencies of any good Housing First support team should include training in these other evidence-based practices. I think person-centered care, harm reduction, and trauma-informed care particularly are very, very useful to have as a kind of a tools in your toolbox in terms of how to work in that modality. It's not intuitive. It does take practice, it takes supervision, and it takes time to learn, but you'll have much better outcomes in engaging people. There is a trickle away. People, it's interesting because we've been watching this Housing First program now over decades. And what you see is that people get better so that they don't need as many home visits, or they may not need home visits or support services as much, but they get better quicker than they get richer, so that they will still need the rent subsidy, like we had public housing or a Section 8 voucher. People, even now, who are working full time and need a rent subsidy because the rents are out of reach for the minimum wage jobs, and they're completely out of reach for people who are on benefits or have a disability. Remember, some of the people we're working with here in the Housing First programs have diagnoses like schizophrenia or psychotic disorders, where just 50 years ago, they would have been in an institution for their entire lives. This is the group, some of the people in Housing First would have spent their entire lives in a state hospital. And we are really at the cutting edge of an experiment about learning so much about mental illness and what people's capabilities are. We have people now in apartments with support services living meaningful lives that was maybe unimaginable 50 years ago. So we're learning a lot. We don't know everything yet, but we are on. I think it's best thought of as a learning in progress, where we should pay attention to what we learn from each other, from other communities, to kind of make this the most effective and best way for people to be included in our community in a way that changes the feel and the inclusiveness of each community. I mean, it's fundamentally about that. You know, what is the place of people who are poorer than us or have different challenges in our community? Do they belong with us, or are we going to segregate them out into some other place? And that's where those people live. I think that's one of those core values, and it speaks to where we are and who we want to be as a community. That your program design is going to reflect the values and attitudes of your community. And of course, these Housing First programs are not don't work in a vacuum. You know, you have an organization that's running a Housing First program. And so it's important that the agency culture and the Housing First culture of the team are all consistent. You know, this is about welcoming people with what we've learned to call complex needs. I'm not sure why we call them complex needs. People who have multiple health and mental health problems have these needs. I think they're called complex because most of our services are highly specialized. And so you have situations where someone has a health and a mental health problem and an addiction problem showing up at the door. And if that door happens to be a mental health clinic, they'll say, well, you know, I can see that addiction is your problem. You need to go to get drug treatment. You know, this is not the place for you. Or they go into a health clinic and they're agitated and they can't wait, you know, in the waiting room comfortably. It's like, well, you belong in mental health, even though their primary illness is physical. So we don't have a well set up system where it's welcoming, but in these programs, what you want is a welcoming culture, this attitude of there's no wrong door. When the person walks into the program, they report all of the different problems that they say, and you say, yes, you are in the right place. We are here to help you. And, you know, and that's not just the case manager. That happens from the receptionist to the, you know, other folks, finance, accounting. The whole organization embraces the values of a welcoming, no wrong door approach, flexibly adapting services to the client. So you see, what I'm talking about is not simple. You know, I mean, maybe you can do all of these things in a small Housing First program, but, you know, and this is the thing about these programs, they're kind of a thorn in the side of business as usual. You know, now you're asking the housing authority to be flexible, and you're asking Social Security to be flexible, and you're asking clinics to be flexible and accommodating and help people that can't quite fit into the cookie cutter approach that all of these places were designed to serve. So that's the question as a community. Are we going to change our ways to make room for people that need a slightly different approach to working? The evidence, you know, and it's important because, and I'm going to spend just a couple of minutes going over the evidence because this is not about opinions. You know, I think that what was frightening in the last administration, where people were espousing all kinds of things, you know, famously, both Carson and Marbut were talking about housing fourth, you know, like treatment, sobriety first, and then housing. It's like, how is that even like allowed, that a public official can disregard 20 years of research about how, you know, treatment and sobriety and then housing? This is a study that was done almost 20 years ago, but it's been a study that's been repeated in country after country. And this study shows the outcomes of housing first versus treatment first. That purple line that you see is the treatment first, then housing approach. And the blue line is the housing first, then treatment and support. Now, this is approximately 80% housing stability compared to about 40% housing stability. This is not an insignificant or small effect that you need a statistical, you know, highly sensitive statistical test to detect. This is a magnitude of change that is rarely seen in studies. So we already know what happens when you do housing fourth. When you do housing fourth, most people don't get housed because it's very, very difficult to treat addiction and mental illness when you're homeless. Whereas housing first, people are off the street, they're safe, and they're working on their addiction and treatment. Of course, the cure for mental illness and addiction is long-term treatment, and that takes a while. The cure for homelessness is housing, and that's instant. So you see what happens is people get housed and stay housed when they have the right supports. And so I was befuddled and quite frustrated to hear housing fourth, like why would that be an option? Why would we want to go back to 40% success when we know we have a tried and tested intervention? This was one study, I grant you, was repeated many times from 2009 to 2014. It was a study this is a study that was done in Canada, and they spent $110 million on this. They paid for the housing, and they paid for the robust support services, and they paid for the research. And what you see in the 5 cities across Canada where this was done, and by the way, all of these are randomized controlled trials. That means that people were matched. Everyone was homeless for about the same time. They have same mental health problems, same level of addiction. And then they're just randomly assigned to either treatment then housing or housing then treatment. So it's the same group getting different programs. It's not different people. And what you find across Canada, Vancouver, Winnipeg, Toronto, Montreal, and Moncton is the same thing we found in New York and in DC when we did the studies. 80%, housing stability compared to about 40% throughout, right? The Canadians had 2,000 people across these 5 cities that were randomly assigned. And one of they did many, there's, if you look at the left-hand corner there, it says Mental Health Commission of Canada. And the project is called At Home Chez Soi, 2019 to 2014. There are over, if you go to that website, Mental Health Commission of Canada /At Home Chez Soi, you will see there are approximately 100 papers written about the quality of life changes, the quantitative results, and there's a bunch of cost studies, notably one by several by Eric Latimer out of McGill in Montreal, where they looked at, well, this was a huge investment by the government to kind of see if this thing would work and is it effective. And what they found on the cost studies was interesting because they had so many people. There's, I'll tell you, 40 cost studies done across the United States. They're typically pre and post, and they typically use a high utilization group, and they show that people who get housing and supports save a lot of money, anywhere between $50,000 to $100,000 a year saved on acute care services, cost offsets by providing housing. Now, this study was interesting because it had people that were frequent users, and they showed the same pattern of results, but they also had people that had not engaged in services at all. They were under the bridge or in encampments and no touching services. So for that group, the cost of engagement of services and providing houses went up. But overall, for the 2,000 people, the thing was essentially a wash. There was a slight saving on the government side when you included everybody, high users and not, that the cost of housing a person is no more expensive than the cost of leaving them homeless. Often, it's a little cheaper. So that's a huge lesson in terms of policy and funding and everything else. Probably one of the most effective programs we have on a Housing First across the United States is the Veterans Program, the HUD-VASH program. This is a map that comes up if you go to the United States Interagencycouncil.gov website. It says, ending homelessness, and you click on that, and this map looks much nicer than the slide. Shows you, the stars show you all of the different cities where homelessness was ended for veterans. They have these cities, 82 cities today and counting, have ended veterans homelessness by using a housing first approach in their HUD-VASH program. Something is happening somewhere around the Mississippi River or the Continental Divide. I don't know my geography well enough, but most of these places are in the east, it looks like, and there hasn't been enough of a dissemination in the west, and we're working on that because there's something amiss there. There was a review by the CDC of 26 randomized controlled trials, and it showed the same thing: 88% decrease in homelessness, improvements in housing stability, 37%. So this was a review of all of the studies by the CDC. This just came out in September, October 2020. But there's other studies. There's studies in England, and there's studies in Scotland. They generally conclude, this is a review of the European studies, and this is something that Ligia Teixeira at the Homeless Impact writes. She concludes that the overwhelming message in the report about the outcomes in the UK and Scotland is that, quote, this intervention that suits stakeholders at every level, and importantly, most participants interviewed were highly satisfied. Above all, it offers great promise that Housing First could be the best evidence-informed intervention in our efforts to end homelessness for good. So that's from an independent researcher. Here's some nuanced things that happen in a community when you introduce Housing First. This is the Pine Street Shelter in Boston, very, very well known in the community. And this is a poor slide, but I'll tell you what it says. It shows you that most people, about 87%, stay in a shelter for 5 weeks or less. And that's true for the homeless population in general. People come into homelessness and then they leave homelessness. They figure out a way, they get a job, a family member helps them out, they bounce back. And so that 500,000 people we're talking about are not the same 500,000 people year after year. It's a constantly changing population. But the group that stays, 13% here in this shelter, they're using up 82% of the bed nights. 13% of the people in this shelter are using 82% of the bed nights. Okay, whereas the other 87% are using only 18% of the bed nights. What that means in terms of like systemically, take like the Road Home shelter or any of the shelters locally, if you're able to move people who are chronically homeless out of the shelter, you would be able to expand shelter capacity without having to build a whole lot more shelters. So in the Pine Street Inn example, if people were staying at that shelter, it's a 30-bed shelter, can serve 548 people if people are staying 20 nights. But if people are staying because there's nowhere to go and they're stuck in that shelter and people are staying 6 months, well, the shelter only turns over twice a year. So every 6 months, a new group of people, same 30-bed shelter is only serving 60 people a year. So you see how shelter capacity is directly related to length of stay. And you can have a much more effective shelter system if you have immediate access to housing vouchers that'll get people out into the community and in rentals, especially for the group that's chronic. What happened at the Pine Street Inn is this light green bar shows you that the number of shelter beds over the course of 10 years is actually decreasing. And the dark bar shows that the investment in building or renting permanent housing increases over time. So when you think about community planning, these are very important lessons learned about what happens. So root causes and what causes homelessness is all about the lack of affordable housing. You know, this thing, you know, it's not about mental health and addiction. It's about the fact that we started having homelessness in the country in 1980, when HUD essentially slashed the budget for the building of public housing. You know, recently, maybe some of you have seen the CSH celebration of their 30-year anniversary, and they're celebrating the fact that they have they've been involved in the development of some 350,000 permanent supportive housing units over those 30 years. 350,000 strangely rings a bell because that's 30 years of effort to build 350,000 units, 30 years. And 350, as this graph shows, is approximately the number of public housing units we used to build in this country each year. Each year, 350,000. So is there a housing shortage in America? Absolutely. Simultaneously, not only is there no increase in the pool of public housing, we're not even talking about building public housing anymore. We're just talking about vouchers. But simultaneously, the rents have gone up. You know, the real estate industry has been incredibly successful, and you know, one of the second highest traded industries across the globe. So everyone's done very well in real estate, but it's left out, you know, because it's all for-profit commodification real estate. It's not affordable. It's not public, and so it's left out people on, you know, fixed income priced out of the market, minimum wage priced out of the market. So we have to address this issue at some point. Right now, focusing on chronic, we can accommodate, but if we're going to really think about ending homelessness, we're going to have to address this issue of how do we bring back sufficient affordable housing. And I have two examples of where, I know I'm like close to the wire here. I have two examples from other countries that maybe help illustrate this, because there are countries, and this is sort of, to me, the amazing thing about this journey and having watched it over time. There are countries that have ended homelessness, notably Finland. And there's a paper by Owen O'Sullivan describing this, 10-year plans to end homelessness in Ireland and in Finland. He chose those two because they had similar populations, similar geographic, small countries. Helsinki is the big city in Finland, and Dublin is the big city in Ireland. They had similar homeless populations in 2008. And then he followed what happened for 10 years after they both committed to ending homelessness by using housing first. 2008, as you remember, the market crashed, and the number of people showing up on the streets in Dublin, as everywhere else, just increased dramatically, as we are currently facing, by the way, with the tsunami of evictions that's going to happen once the rent moratoriums are suspended after, you know, because of the COVID. It's another story. But in Ireland, they panicked, and the government started to build more and more shelter beds to get people off the street. There was a lot of public pressure, and this is why public opinion and public policy, public opinion affects all of this. The Irish decided they were going to build more shelters because they couldn't bear to have people out on the street, and they went from 600 shelter beds to 2,245 in the 10-year period. They ramped up their shelter system. The Finns stuck to their guns and began to close shelters. They converted the existing shelters into studios, and this group called the Y Foundation, which was a combination of business, government, and the faith community, which actually is a great tripartite partnership for the state of Utah, because that's what happened when we ended homelessness in Utah the first time, when you ended homelessness in Utah for the first time. Faith community, government, and business, magical combination. And the Finns began to build, buy, acquire all possible types of housing in the country, mostly in Helsinki. And so in 10 years, they acquired some 12,000 units under the control of a nonprofit Y Foundation, the letter Y Foundation. And all of this is written up in English if you look up Y Foundation. You might find it interesting. So what happened to homelessness then with these two strategies? One, shelter, and the other, let's get as much housing as possible. Well, in Ireland, the homeless count in 2008 went from 1,200 to 5,500. The more shelters, the more homeless. And in Finland, the homeless count went from 3,200 in 2008 to 1,087 in 2016. But today, the number of shelter beds in Helsinki is 52. 52. The number of permanent housing units available for people who are homeless to get out of the shelter quickly is 15,000. Okay, so I know they're different countries, but the lesson is there. Locally, Milwaukee County, Bergen County, and Montgomery County have ended chronic homelessness. They ended veterans homelessness, and then they ended chronic homelessness. And they did it in exactly the way that that we were talking about at the beginning. You know, if you go back to Mr. Niederhauser's comments about the collaboration, that's how these counties have ended chronic homelessness. They have a housing authority issuing vouchers, outreach directly to the housing authority. You know, the coordinated entry system is not fueled by the VI SPDAT. We've learned something about that. It's a biased tool. It's not reliable or valid, and it's a prejudice against women and African-American women in particular. It underscores them. So we've gotten rid of that, but you can have a coordinated entry system based on real data, frequency of hospital use, arrests, you know, actual data rather than a quick checklist. And that worked well for them. They have everyone around the table, including, by the way, the district attorney, who also does outreach and adjudicates all of these tickets and violations for homeless people, so it wouldn't keep them from being eligible for the voucher. They have people looking for housing, and the county, the city of Milwaukee, and all of the providers are all on the same page about adopting a strategy to end homelessness led by a housing first approach. So we come full circle to what matters is the consensus of a community to think about what is it that we want to achieve and how are we going to achieve it. The program has expanded to include victims of domestic violence. Women especially are more likely to leave abusive relationships when they go to an apartment with their kids rather than go to a shelter and then change schools and all of that disruption. Youth and indigenous populations. So that's, you know, that's what we've learned. I hope that this has been useful in terms of your considerations of where Utah goes from here. Community-wide approach, increase access to housing, wraparound services, timeline, measurable goals, leadership and sustained efforts. I think you have all the ingredients at the table. The question is, how will you get it together with a vision and a consensus to go forward? And I wish you all the best with that. Thank you very much.
Thank you, Doctor. We appreciate your presentation today. Awesome. We have some time now for some Q&A, and I'm gonna let Stephanie guide us through that. I noticed there was some questions in the chat. Stephanie, do you want to?
Wayne, this is Trisha Davis. And so I'll be guiding us through this.
Oh, Trisha is. Okay,
Yeah,
great.
quick change, sorry about that. So Dr. Sembraris, thank you so much for being here. We've just enjoyed having conversations with you in this planning and really appreciate your insight. The first question is, preventing homelessness is also a focus for many. We've seen some of the problems with sober transitional homes. A shared housing formula leveraging accreditation for higher quality options for homelessness seems to be gaining traction and is successful in Washington, for example. Can you comment on these programs for recovery, transitioning from prison, veterans, and special needs groups?
Yes. The most important thing that we can offer someone who's homeless is a place to live. And so the more options that we have in our offerings, the more likely we'll succeed. It's not unusual for people to be offered housing and then choose to want to go to treatment before they go into housing because they want to be in a stable place and have a new, fresh start. So that's important. I think that the idea of people leaving prison, one of the partners around that table in the community planning has to be corrections. There are very good programs, for example, where corrections is actually putting in their budget money for housing and supports, essentially a housing first approach that corrections is paying for because they don't want people who are constantly returning to their jail or prison because of crimes of poverty. So there are resources and housing options, and certainly for the veterans, there's a robust HUD-VASH program, and the ability to offer someone a place of their own, a recovery house, a shared housing with other veterans, all of those things, the more options we have to offer, the more likely we're going to find the match for that person's needs. So I think, I guess I would, I don't think of an encampment as housing. I don't think of like a tiny shed as housing. I mean, it has to be, let's just get the definition right. Housing has to be actual housing where the person is a tenant and has a lease and has tenant rights and has to pay the rent. Like when we're talking about housing, we're talking about actual housing.
Thank you. The next question is, how long or often will individuals receive personalized support and home visits throughout their housing journey?
Oh, for how long? Well, it's very much a person-centered program. And so some people, both the duration and the intensity of services varies over time, so that some people may need a lot of services, typically in the beginning, and there's this whole intervention about a critical time intervention, which really speaks to the fact that if you're running a housing first program, you should expect to visit people a lot in the beginning, and then it tapers down, and then people may have a crisis, and then you have to ramp that up again. So there's a modulation of intensity, and the duration absolutely depends on how well the person is doing and how quickly they get there, so that you can be dropping off the intensity over time until eventually you get to the point where it's agreed the person has their own provider in the community, they no longer need the home visit, and there's a graduation from services. There isn't a prescribed length of time, it really, that's the thing about it. I mean, the principle is you provide services for as long as the person needs it. You're working on an arc so that the idea is you're helping people, but teaching skills so that the person doesn't need you, and you want to be basically out of that provision of services when you can. So it's more of an educational approach to liberate the person from needing the services. But it's hard to put a timeline on it because it depends on what baseline the person is starting from and how long they might need services. some people graduate from the program because they develop other social supports, and were essentially replaced. They don't need a case manager. They actually have a family member or a friend or a significant other, and they graduate that way. Other people, reconnect with families and move back, and they become the support. Others are just, are going to be with us for a very, very long time because they don't have anyone, and there is no one to replace us that way. And so I think you have to be prepared for all of that.
Great, thank you. The next question is related to assessment tools. As many communities throughout the nation and states throughout the nation are looking at assessment tools right now, the question is, are there any recommended tools or guidance on a new assessment tool that might replace the VI-SPDAT?
Yeah, well, that's the question around the COCs around the country. What is the new assessment tool? And I don't, there's a couple of tools that are more being used. There's something called the Multinoma. It's like a multi-domain approach to assessing people's needs. There's something that is done out of Seattle called the it's a DESC. I can't remember the acronym for it, but it's a vulnerability index. But it's not the VI-SPDAT. It's the vulnerability index developed by DESC. Here's the thing. I have to just, I'm a psychologist. I've spent a lot of time studying assessment tools and all of these things. I don't think there is an assessment tool. I think we can have maybe an initial checklist that's better than what we were using, but I think we really should depend on actual data. The Milwaukee example I gave, where they've ended chronic homelessness, they were basing their prioritization in their coordinated entry on hospital data, on police data, on the knowledge of the outreach worker, of the person. So I guess I would, maybe that seems a little bit more time consuming, but I think if you want to get it right, it would be best to use actual data than a quick checklist that's done in the field, at some point in time.
Great, thank you. The next question is, what does it mean when you say Utah did at one point almost eliminate chronic homelessness? And can you walk us through your best understanding of how we got back to where we are today?
Oh, thank you. I was meaning to actually address that, so I really appreciate that question. The way we got to zero was there was an enormous amount. There was an enormous investment of resources. There was two, at least that I was aware of, a 75-unit building for singles. There was the motel conversion. There was lots of subsidy. There was a commitment by the shelter to bring people that had been chronically in the shelter into housing units. There was a momentum, and there were enormous resources committed at that time. And as the resources ramped up, the numbers went down. It was magical. It was just the way it ought to be. That's, the consensus was huge. I mean, Lloyd Pendleton was leading it, but everybody, governor, mayor, faith community, business community, everybody was on board, providers. So 90% reduction. And what happened? Well, this is the main point. Homelessness is not a pool. When we count people who are homeless, it's not a pool, it's a stream. If it was a pool, then we would have been at zero and stayed at zero. You take the water out of the pool and there's no more water, it's gone. You've housed all the homeless people today, there's no more homelessness, but that's not what's going on. We are at the mouth of a stream. And the stream is there's not enough affordable housing, wages are too low, people with disabilities on fixed income, if they fall out of housing, they're going to be out of housing. We have, the commodification of real estate, all of that systemically, structurally is creating homelessness much faster than we can end it. We're down here at the mouth bailing people out of homelessness. But for every person we bail out, the stream is dropping another 1.5 people in. So we have not reached a point where we have enough outgoing services to accommodate people coming in. That's why I brought up the example of Finland, because it shows that when they ramped up and they had 15,000 units, and this is not, they only had 3,000 homeless people, right? 15,000 units. Why? Because it's mixed income housing, so that they bought these buildings, they had people paying full rent, they had people on subsidy, they had, and then in a 15,000 unit, there's lots of turnover at any one time. So that they had so much on the housing side that as people fell into homelessness, somebody dies that was supporting someone, a fire, lose a job, all the same reasons people will get homeless, but they were homeless for like a very short time in that they only needed 52 beds because they knew they could exit. So it's not a pool, it's a stream. And what we learned from the Utah experiment in very vivid ways is that you can actually empty the pool, but it's not a pool. The pool is just the end of this stream. And unless we go upstream and prevent and address the affordability issues, the income issues, we will continue to have homelessness, and we will be in the homeless businesses and having these summits forever.
Thank you. So we have just a few more minutes, but I want to get a couple more questions in here. There's a lot of great questions we're not going to be able to get to, but so first, what would you, and I'm going to change this question just a little bit, but just to our person who posted, what would you propose for clients living in shelters, I'm going to add, or unsheltered homelessness that do not want to engage in finding housing themselves or engage in services?
Yeah, that's exactly who we want to work with. I mean, remember, this is not about housing. I tried to communicate that. Housing first is about people first. So it doesn't matter that they don't want to engage in housing. It matters that we engage them at all. Like, what is it that they want? And what are they about? So it's really, that's the challenge. I mean, everyone has a story, why they got there, how they got there, why they feel hopeless to change it. But it doesn't have to result in housing right away. It really has to be an engagement right away. And then as you get to know people, I guess I do start from the very strong belief and experience that everybody wants to be doing better than being on the street. I take that as a matter of faith, that people want to do better. And so the question is, how do we find that kindling, that spark to ignite for them? How is it that your life can be better? It may not be about housing initially, it might be about something else. But the important thing is the engagement. So if you have, and if you're working with someone that's being, not interested in housing, doesn't want to engage, I think that's a great challenge. I think that's you're working with exactly the right person. That's who we want to engage. We want to help everyone. There's a place for everyone at the table. And I would persist and continue and visit back and bring sandwiches and, find out if they, what their favorite food is and what they like to talk about and build from there. It's not, this is about people changing huge attitudes, beliefs, paranoias, suspicions, disasters, shame. It's a lot of trauma, and a lot of trauma, and a lot of trauma. And that leads to a lot of, distrust and reluctance to engage. So don't think it's, we're going to go and we're going to say, here's housing and people are going to take it. That does happen, actually, surprisingly frequently. But when we find someone not interested in that, that's where we can actually develop some better skills.
I love it. Thank you so much. We are out of time, but Dr. Semberis, I just appreciate you being here so much. Big thank you from the Office of Homeless Services. I wish you could hear the massive applause that's happening right now. Maybe someday when we're back in person, we'll have you here again.
Well, thank you so much for inviting me. It's always a pleasure to visit again. I hope it is in person one day. Yeah.
Thank you. And I'll turn the time back over to Wayne really quick for some housekeeping.
Yeah, thank you again, Doctor. We appreciate you being here. A couple of housekeeping items. We do want to recognize, though, our state homeless council. Tricia, you want to put up the list of council members, recognizing Whitney Clayton and Gail Miller as our chairs. We kicked off this homeless summit last night at the Jordan Commons Theater. We appreciate Gail Miller and providing a place for us to view the invisible class. And we also just want to thank our service providers for all the good work that you do. We look forward to a great conference over the next couple of days. Housekeeping. As a reminder, links for all sessions can be found at jobs.utah.gov, homelessness 21 agenda PDF. In the last column of the agenda, all attendees will be muted automatically during all sessions, but will be unmuted to speak as necessary per discretion of room moderators. If you have a question or a comment, please type it in the Q&A function found at the bottom of your screen at any time during the session. Moderators will do their best to get through as many questions as time allows based on a first come, first served method. Each session will run in the allotted time, and it is important to end on time to prepare for the next session. If you are on a phone and have been unmuted to speak, you may also need to press *6, right, Stephanie? That's off my paper to be heard. So again, thank you for your attendance. Lived experience panel is next. Red Barn's approach to solving homelessness and solutions for overcoming barriers to housing. Thanks for being with us.